started the session.
Okay. Okay. Hi, my name is Dana Kirkpatrick. I'm a licensed professional counselor and certified sex therapist and certified sex therapy supervisor, which means that I can certify people all over the United States and internationally. And that means not just counselors or sex or therapists, it can be medical providers for ancillary providers. So I'm trying to always be out there and talking about what we do. So a little background on me. Um, and let me I can present my screen. All right. Can you all see that? I'm sorry, I just want to make sure you can see that. Okay.
Yeah, yes, we can.
All right. I don't use Zoom. I use Google. So I always have to just like toggle to make sure I'm seeing what I'm seeing. All right. So the other big thing that I always like to start with is not only am I a sex therapist, I'm a cancer survivor. I had breast cancer at 31. I'm 48 years old. I have the BRCA2 gene. So that is, I have, this is in my intro. I also was raised with no money, and my mom had breast cancer 3 times, actually. One time passed after I did. But so I grew up, as I always called her, the original young adult survivor. So I had a lot of privilege in the sense of being around tons of doctors my whole life. And I have ADHD. So I've always been very curious. I didn't know that obviously until my kid was diagnosed. So I've always been very curious about, the human body. We called my mom a padiddle because she had one breast that worked. So when other kids would punch buggies, I'd say padiddle. My mom has one of those. So now, then having my kids grow up, we talk about these things that are, essentially body, just normal things you see in the medical community. But I had to break the glass with that with a lot of people. So as a therapist and going through becoming a certified sex therapist because I worked with a lot of couples. So that's kind of how I started and got interested in it is I would ask couples about their sex life and they acted like no one had ever asked them before. But then being a woman with bilateral mastectomy, with reconstruction, no one talks about feelings or the idea of like loss of feelings or what sexual pleasure means because you're supposed to just be happy that you didn't die. So that is a very integral part of my practice is representing people that are underrepresented. And that is a lot of what you're seeing, especially at WVU. We see it up here where I was treated at UPMC, is my doctors always said, be aware that people are driving far for these treatments. So you're going to see all kinds of people across the spectrum. And that's what I feel is I end up seeing is a lot of people that are just outliers in little areas. And then, this is part of where sex therapy comes in. So anyways, I like to start with that because those two things you'll see my ADHD kind of poke around as I'm talking. Also because I lived in this world for so long. I'm 48. So my mom was diagnosed when I was 5. So I have 43 years of lived experience in the medical community as an impoverished person, as a child of somebody, as a patient and as a patient advocate, and now as a provider and as a parent, as my daughter has a lump in her breast that is benign, but we're also dealing with these kind of longevity issues that, take the fun out of a lot of conversations like college and things like that. I also put on there's a counseling division for the ACCSW, which is the Counseling and Sexual Wellness Division for counselors for the association. And I'm the social justice chair. When we talk about social justice, a lot of the things that I try to advocate for are it doesn't have to be on the spectrum of like provocative rights. We're talking about medical rights for people to have pleasure, medical rights for them to just be able to address fertility, things that are related to pain or lack of pleasure or fertility without worrying about are they allowed to, or are they entitled? So these are some of the terminology that I just like to make sure that people understand. Um, sex therapy in general. I hate that title because we're always trying to explain to people. I have a lot of people who say, well, I'm not having sex, so I don't need to see a sex therapist. And it's like, well, it's not a verb therapy. It is a function of what issues that you might have that you can't talk about with other people or you don't know who to talk about. Pelvic pain and desire. You all, you know, pelvic pain, BDSM and kink, out of control sexual behavior or sexual addiction. I just taught the nurses at RMU the other day, and they wanted me to teach about sex addiction. And I just always like to clarify that as a sex therapist, we don't look through the lens of pathology and addiction, because when you work with multiple cultures, what is seen as sexual addiction can be seen as, it could be just gazing at flesh at some point. So how could you can restrict somebody from a world of heroin. They can actually live their whole life never having heroin. They can, but I try to live your life not seeing skin or something. So we talk about out of control behaviors. So, but in the term of addiction, it's the same as like shopping, gambling, those kind of process addictions that you never can, if you're a food addict, you have to eat. So we want to talk about as a compulsive, it's the same as like compulsive eating. The LGBTQIA plus in the sexual minorities, I always like to like just give a little blurb of like, I've been married 25 years. I have 2 kids. Gay people don't come to see me to learn how to be gay. They come to see me because they have ADHD or whatever thing, or their neighbors drive them crazy, or their medical providers drive them crazy, and they need to learn how to speak to people that I represent. So we do a lot of those things. It's not you, because we see a lot of people that they think they have to be an expert in each area. I work a lot in the trans community because I've had surgery, so I can relate to them. So we have those crossovers. Being sex positive or sex positivity, think of why people come to see any doctors. They don't come to see you because they're doing great. They come because they're in pain. They come to me because they're struggling. So we try to make sure that we put it in a positive notion of, what do you seek pleasure? What is a good thing about your sex life instead of what hurts? Polyamory or compersion. Okay.
Dana?
Yeah, it said the host
Okay.
muted me. Okay. I thought I said something off the wall or something. No. Okay. Since Elise is here, she can speak to this next example. So polyamory, is used a lot of times, for multiple relationships. And then compersion, that word is used in collaboration with polyamory. Has anybody ever heard of compersion before? Okay. So Elise was present in a moment that I got to call it out. So I was raised Italian, Irish Italian, happy St. Patty's Day. But as an Italian, one of the things that we enjoy so much is making food and then watching people eat the food we make, or having people eat the food and us, and enjoying them watching it. So Abby, who works for us, or used to work for me, she's a marathon runner and ran like a 50-mile marathon. So she's serious. And that's one thing. The other thing is, we in my office in Lawrenceville in Pittsburgh, it's near a really great sourdough pizza place. So they have it's a Bianca pizza that has like it's a white pizza. It's so good. So somebody like Abby, that's this like elite athlete, and then I have this pizza there, and we're doing supervision. Elise is sitting there, and Abby takes a bite of this pizza and she just goes, "Oh my God, that's so good." And I said, that's compersion right there. That is what compersion is. It doesn't have to be tied in with polyamory of like, the goal is to have because what it's taught as a lot of times is having my partner or somebody I love have sex with somebody else makes me feel satisfied. But that's just the sexual version of compersion. Compersion could exist when you look outside and you see your spouse playing with your kid. That's, oh, I love them so much. I love that they love this thing. That's what compersion is. So, I always try to teach people that. And like, if you do love food and you love watching people eat your food and things like that, that's an easy way to demonstrate it and introduce this idea of like, we should know that word because it's based on pleasure. So those are not words that we really know. But think about like kids, we should be able to teach them like, oh, don't you feel that compersion when your friend plays with the toy that you introduced him to? That should be what it be. But instead it's tied in like to sex, and it's not a sexual word. Okay. Anorgasmia, erectile dysfunction. Always, you guys see that a lot. I think anorgasmia in the medical community too, we have to probably address it sometimes. We have a lot of people that I see that come in because they have a lack of orgasm, but it's been addressed to them as a binary of like, have you had an explosive orgasm? Yes or no? So we have a lot of women who say, I don't, I have anorgasmia. I've never had an orgasm. And when we talk about levels and what that looks like, then they're able to understand that they're not failing, because it seems like failing. You're not having something and everything's in this binary. Same as erectile dysfunction. And think that if they can't have something right away, then it's gone. Um, and you can see this in like the real right now. There's a show on HBO called DTF St. Louis, and one of the guy, I can't think of his name right now, but he's from Stranger Things. His presenting issue essentially is that he has Peyronie's disease, and Peyronie's disease, in my 26 years of doing this, have only encountered one person that actually had Peyronie's disease. But I know that there's drugs out there to treat it. So now they're advertising it more, and now you're going to hear about it more. But in reality, it's something that is a very rare thing. But men will think, oh my, I have a curve in my penis. So I have erectile dysfunction. I have Peyronie's disease. Well, 100% of men have curves in their penises because penises are like curves in your ear, right? So it's just this like how to look out for these things and not pathologize. The other thing, one of the main things that we see is cultural minority issues. And this is not what the way, and I'm sure you see it with at WVU with in the field of medicine, is anywhere there's teaching hospitals, there's crossovers of tons of different cultures. And it's not even like this white versus another culture. It's cultures intermixing with other cultures and the same cultures intermixing. One of the women who works with us who's a pelvic floor PT, she's Indian and her husband's Indian, but they're of different religions from India. There's 800 religions in India. So looking at like how those things come out and what that means for modesty, what that means for dress, what that means for sexual expression, sexual acts, those things are very different than what is presented sometimes in American culture. So I try to be very curious about those things and not judgmental, and make sure that the clients are educating me. We've had, I of course, as a therapist, hear the bad parts of what a medical provider said something very insensitive to. Like I have a client who's Sikh, who Sikh people, as a religion, do not shave. And he went into a pelvic floor person because he was having issues, and not a pelvic floor, it was a urologist. And the urologist was like, well, if you shaved, you wouldn't have these issues. Like that is a very insensitive thing to say to somebody. And so that's why we're just practicing sex therapy is not just about dysfunction. It's about being able to be inclusive to all kinds of people. Okay. So this is all these, I kind of talked about these things in conversation. I'll just go over them a little bit too, is, being sex positive, what that means is being curious, not judgmental. Polyamory, it's not newer, it's existed forever. It's just new in the zeitgeist now. So people are identifying more as polyamorous, or having open marriages, or these different levels. We talked about compersion, purity culture. At my practice, because I have ADHD, and not just that, but because I can't see certain aspects of things, I have to address my own ignorance. And one of the things that we have is Brenda, who works for me, who does our intakes, is a pastor. And she is a sex positive pastor. She has an adult child who's trans, and she helps me address like these. She has groups for purity culture. You see it in WVU with different people with it, like coming from different backgrounds. It's not purity culture itself is bad. It's some people that come out of it have scarring from that. So just looking at how to address that in a inclusive way that is respectful to their desires to remain religious. And I think that's sometimes what we would see is there's a point where this intersection is broken a lot between religion and sexual positivity. So I try to make sure that we bridge that gap and address that. And Brenda and I have done that together a lot of times. The LGBTQIA population, again, the out of control sexual behavior, we talked about that. The minorities, in sexuality. If any of you watch The Pit, that's based in Pittsburgh, I haven't seen this episode, but they said that they had a furry on it. That's something when we think of like sexual minorities, it goes to like, oh, these furries. Really, in all reality, there's a small minority of furries that are into sex, but the rest of them, are just people that are geeking out about different things, or people on the spectrum or whatever. BDSM, bondage, domination, sadomasochism, been around forever. 50 Shades of Grey brought it back into the ether for everyone. It's something that we talk a lot about with consent, because these minorities, of when we're providers, we have to be able to be, I would say, inclusively supportive. So I use this like kink is just an overall term for people that are into something, but they don't identify what specifically that is. Uh, um, ABDLs, adult baby diaper lovers. That is something you will see every once in a while. For example, we had somebody request to wear a diaper to the office, and one of the therapists, or it was somebody at the time, had said, like, should I say yes? And I was like, absolutely not, because that's allowing fetishization into the space. Like, if nobody who has to wear a diaper for physical needs would ask to wear a diaper, this is acting out a sexual fetish. So it's sometimes those things of like, and I know I have people, these communities have experts in those communities. So making sure that, you're not just saying yes to something because you want to be respectful, when really it's allowing something that shouldn't be allowed. Um, People that are ace, so you'll hear like asexual. A lot of times they refer as ace. And that can be varying degrees of that sexuality, and how a lot of times my ace clients are okay with themselves. It's how to explain to people in their lives that worry about them being alone, of how to explain that, or that maybe they do have sexual desires. It's not that part. um Swingers, that's, everybody has heard all the different rumors about those things. They exist everywhere. It's, this is somebody who sometimes they have partners and they're not in relationships, like polyamorous people. They might just go to sex parties, sex clubs. A lot of places, I just helped a couple that wanted to go to like a swinger party, but they didn't want to do anything, and they wanted to make sure it was very safe and consensual. So I just help them get like critical thinking skills together of what things to do, look out for. And they found a place in Toronto, and it had, it vetted they had disease prevention, they had consent laws, they had all these, like, every single thing that makes somebody feel safe. So that's kind of what I'll do sometimes, is just, I don't tell people where to go. I help them use the tools to look at where to go. The same with medical providers sometimes. Intersectionality, again, that's just, talking about all these different things that show up. Autism, we see a ton of people on the spectrum, and then anybody who is highly intelligent. And those two things sometimes go together. And then we see like the sensory needs and these other things that play out. The medical issues, chronic pain, diabetes, PCOS, all the trans health issues, infertility and orgasmia, survivors, and then erectile dysfunction. I just put all those things in there. You guys know all these things. I have type 1.5 late onset diabetes. I think that plays much more of a daily role in my life of like issues compared to breast cancer sometimes, and addressing those things with people, addressing hormone changes. When I was teaching the nurses last week, I said, if I seem aggressive, I have ADHD. I'm a strong-willed woman, but also I have no ovaries and fight estrogen. So I kind of have like a little bit of teenage boy mentality in me. So understanding that, and I understand that from my perspective, but understanding that in trans health sometimes, looking at what hormones they're coming on and which ones are going in, so to identify those mentality issues that come out in their relationships too. And then advocacy, I just did a talk about anti-conversion therapy, and then sexual self-advocacy. A lot of people that I see that are have medical issues, they're taught to be grateful. Like, and I'm supposed to be grateful I'm alive and not worry about my sex life. But when I was 31 and had cancer, that's something you don't have the privilege to just like let go of in your 30s all the time. So, or desire. So working on those. Nutrition, we also have a dietitian at our place because this comes in a ton. And our dietitian is white from America, but Raj, who works with us as a pelvic floor therapist, is from India. And one of these little identities that we see are Indian people that come to the United States. They have stomach issues that lead them to have other issues. And part of it is because the Indian diet in India is very different than the United States. There's not like bread and lettuce all the time. So just even those little things of just thinking outside the box of that. And then the pastoral care of where this leads and how this kind of how to spiritually be okay with yourself if that's part of your desire, having um, Brenda do that. Sorry. Okay. Does anybody have any questions or anything? I know I'm talking very fast. I don't know if that's part of this or not. Okay. So the common misconceptions, these are just things that I've heard. And like I think it's very silly sometimes when like it comes to a crowdsource point where it seems that everybody should be having sex during the day with the lights on, with no lubricant, no help, and they should just all love it. And I think that's, that where does that come from? It comes from nowhere. So looking at like gay men only have anal sex. I've had gay men who are afraid to come out because they don't want to have anal sex. And I said, like, who said you have to do that? Or that cis women don't want sex, or sex only happens when both people are in the mood, like the spontaneous desire collapse kind of thing. That lesbians only use strap-ons. I've had to tell so many men that is not true, or that orgasms have to happen at the same time. And I mean, one of the big ones is that body response equals interest in sex. And all of you who worked in rape know that is absolutely not true. And I had a woman come recently who she came to see me because she had from her fiance reported, he said, there is something really wrong. Something smells down there. And I don't know what it is. Like something's wrong. And she went to her OB, and the OB said, and I quote, maybe he's not the right guy for you. And that's what your body's telling you. So think about that. And if our bodies could tell us that, every rape would emit a giant a smell. So she went through the world with that shame. And I told her, like, that's not, obviously not a thing. She goes to see the pelvic floor therapist not instantly, but was fixed pretty clearly because it was a hormonal issue. She had been introduced to birth control prior to having menses. So she had this internal dryness. No amount of talking was going to do that. And the idea that she got traumatized for talking about it is doubly hurt. So then it doubles the work that we have to do. The other thing, and I'm just going to put this out there because sometimes you have to deal with this. And I think, Elise, I actually consulted with you about this, is spontaneous ejaculation. Because I had a guy who he had issues twice where once he was getting hair removed from his back, and once he was getting a massage and spontaneously ejaculated. And those are very scary for men, obviously, because that can lead to like sexual assault claims. But the important part for me was I sent him immediately to his PCP because I consulted with the pelvic floor PT, and I just said, this sounds very weird to me. And as a cancer survivor, it sounded really weird because it was like in his lower back and his upper back, right? Where like some kind of, whatever, but it sounds more like a tumor issue or something. And so those kind of things. But when he asked a doc, like to get laughed at, or people look at you like you're crazy, it causes just years and years of damage. So that's why I always operate with curiosity constantly with things. So again, how to approach things, cultural competency versus cultural humility. The difference of that is, I use this when teaching is, yeah, I'll say this, like Nanelle, who works for me, is Black. She does not call herself African American. And the cultural competency would have me say, oh, no, Nanelle is African American. But if Nanelle was here, she would say, I'm Black. So the cultural humility is speaking to that language. So when I'm talking in space and in a classroom, and I use that example, there's usually a Black person in the audience saying, oh yeah. So it's that, but who says being culturally competent is different than kind of going in. And so, I mean, cultural competency teaches you to be good enough, whereas cultural humility is actually going in and understanding what the person wants. So thinking of it as like, legal name versus what they want to be called. It's, checking in with that person. Um, Using antidotes of like, so I mean, I was saying with the cultural humility, I ask people what they prefer, what they want to like, what their identity is, what culture that they relate with. Like I'm Irish Italian, but I'm very much more Italian, like in the way I identify. Using antidotes about like normalizing these things is like I always say I have a whole job filled with this because people need this. Because I have every new client will come in and say, I'm so embarrassed to tell you this, or you're never going to believe this, or this is so gross to think about. And so then I'll use humor. And one of the best things that I can always use and you can always use is everybody poops. It doesn't matter how rich you are. Taylor Swift still gets diarrhea. She does. She still grows pubic hair. It doesn't matter how fancy, even if she gets waxed, somebody's going down there. And so just to take that, like, because everybody's living in these worlds where they think that no one else is affected. So I use it as the idea of like men are getting programmed by porn, women are getting programmed by Instagram. So how can we just pick your head up and say, hey, those normal people, they haven't, they haven't fixed that problem. They're still pooping. They're still pooping at you. Like, get over it. In sex, that's a major issue, is pooping and peeing. People can't even, if I just bring that up, they'll be like, and I'm like, you're going to talk about all these weird things, but you can't talk about poop. So that's sometimes we'll just, that base of like, what are you putting into your body? How quickly are you putting it into your body? And are you even around? Um, and then again, valuing clients. I am very client centered. I have had services my whole life. I am a benefit, I had WIC, I had all these things. So I feel that it's very imperative to be, look at them as this, what they're bringing to you, which is very vulnerable and it's so, I always think that they're like just opening their whole body to you more than just like a gynae visit. Okay. And then, this is just something I put like, don't minimize their experience or perspective. I have a friend on one of the Lawrenceville Corporation group with me who's a business owner, and I met him one time and I said something about being a cancer survivor, and he said, oh, I had a sarcoma on my finger one time. And I took his finger and I said, dude, that's a sarcoma, you had cancer. And I said, you had cancer, you had a sarcoma in your finger. Like somebody died, lots of people died by that. And he just went, wow, wow, you're right. And I was like, yes, like don't minimize it because it's your finger. Like I totally get it, but it's also like, so now when I see him, he'll always say, hi, cancer survivor. I'm a cancer survivor too. And I was like, yes, because it's not to get attention, it's to spread normalcy, to say, oh yeah, I had that. And look, I have my finger because they found it early. Hey, I had reconstruction. They found it early. So it's, looking at it like that because I think a lot of people they feel like they have to explain why they're there to see you and why they deserve to see you. Join with them, show support, tell them how none of you are going to say like, oh, the medical community is great. Everything's great, because it doesn't matter how great the providers are. You're still dealing with insurance companies. You're still dealing with just the hierarchy of hospital issues. So that's where I'll just say like, this sucks. Nobody wants to be in this. And it's not fun. My mom went through it in the 80s and it was better in a weird way because it was HMOs, but then she would have died if she didn't have research. So it's the whole system just sucks a lot of times when they present with you. Psychoeducation. I talk to people a lot about cancer in general, medications, the side effects. I was on a trip with girlfriends this weekend and we went and got massages. I always get like body scrubs because I can't lay down for that long. And my one friend said, oh, I could hear you talking. Why are you talking the whole time? And I was like, listen, you like to be quiet. I don't. But also, do you have to tell every person that you encounter that you had a disease? And she said, what do you mean? And I said, I get a massage. I have to tell them I have breast cancer because I have implants and I don't have feeling. And also I have to tell them I have breast cancer because I have hot flashes. And then also because, they could hurt me and sometimes they don't want to do that. And also I have diabetes. My sugar could low. And she just looked at me and I go, no, seriously, like every time I go to any appointment, I have to tell people that. Like I don't get pedicures a lot because I don't want to explain to people about diabetes. So it's that idea of like, give them the onus of understanding, like if they have any of these things and they're seeing you, they have to also carry this burden of whatever the side effects. I was taking Boost Bar to help with the side effects of Adderall. And I have to take Adderall. Like it's all these like side effect things. And when you come in medically sick, a lot of times you're going to have these different side effects that are going to affect your sex life. So like the idea of like feeling like shock, it's going to be having electric shocks or having lack of desire or coldness. We talk about sensory issues. I have people that I encourage them to use like blow job spray or numbing spray on their mouth for kissing because they have so much dryness. And I know I'm on stimulants and it is constant dry. If your mouth is dry, other areas are probably dry. So just educating on that. A lot of people are prescribing Vistarol. Vistarol is great, but it's also a lot like Benadryl. So it's going to cause dryness sometimes. On trauma and trauma responses, I had to do that during the pandemic with masks. I had to tell people, oh, I had some PTSD about masks, and they didn't understand because last time I saw people in masks, they were standing above me. And just this idea of simple kind of using that trauma of like, you're here, you're not here for fun. So let's just like give your body a chance. You're probably going to have some anxiety. Sleep and hygiene, just basic stuff of like I did 2 Pilates classes this morning because that's the like thing that helps me sleep. It's not the thing that helps me lose weight, but it's the thing that helps me sleep and helps my brain. So it's like, what are those things? Because sometimes sleep is integral. Sleep's always integral, especially for sexual functioning. But just to make sure that how are you getting that? And it's not restless. We have a lot of people that they sleep a lot of hours, but are restless because they're not using their bodies in effective ways. And then, I said impact too. Sorry. Research-based, like using cognitive, thought-based, somatic, body-based, and mindfulness. So I use that with symptoms and things like if you're getting treated for something in a medical setting, you're going to have medical trauma in the sense of like your body's going to respond quickly. So how to retrain your brain, give yourself permission that it's going to be somatic. How do we calm our body down? So if you do it, like I've been a product in many hospitals where they've had to say, we're going to leave you alone for a minute and have you lay on your left side. Can you hug this towel for me? All of those things that are just basic body-based strategies that you all can use to just get people, again, back in their bodies, because that's the stuff that helps for sex too. Okay. This is just, I've talked a lot about, all of these things already. We use, humanistic CBT, trauma focused, person centered, and then with sex positive changes and assess trauma. I try to focus on the idea of talk therapy because a lot of times in sex therapy, we have to almost be provocative because people don't know, they don't have the language or exposure of these things. So if we constantly say, how do you feel? How do you feel? How do you feel? They might not know. You guys have all felt compersion at some point, and you didn't even know it till I introduced it to you today. So if we don't introduce these concepts to them, they're not going to understand. So that's when I kind of pick and pull from different aspects and say, this has happened or this has happened with different people, just to assess them. Because also when people present with trauma, I have some people that have trauma it is gang rapes, multiple. And then I have other people that have broken their leg. And those two people realize trauma the same way or are affected the same way, and how to like get that impact and understand, because a lot of times the gang rape people act like it's no big deal. And the broken leg people are like, I can't work anymore. I broke my leg. You don't understand. So it's how to kind of lift them up a little bit to normalcy and gauge those. Referring to pelvic floor therapy, again, I talked about like the, vulvodynia and vaginismus, but then the sensitivities, erectile dysfunction and incontinence. So a lot of times I'll just have people just meet with a pelvic floor therapist just to see, because sometimes it's diet focused, sometimes it's muscle memory. So, I said about Pilates, the one thing I love about Pilates is you put your feet in straps and you're moving your legs around different ways that you're not doing usually. So like, but I see a lot of runners that have pelvic floor disorder because they run so much and their legs, they're not used to the rounding movements. So then they get very stiff with sex. So using that same, like, how do we just help people see what their palate is for movement of what they can do to be complementary to get the muscle memory. So you're going to be able to lay down in a bed and be examined if you're doing that all the time. But if you're not moving your legs around and all those things, that's different. Okay. So the other thing I was going to think real quick, we work a lot with amputees also. And, I obviously didn't walk with my breasts. So they're not like, I don't consider myself an amputee, but having things cut off and living with like any of that numbness or lack of feeling are very important. And we work with Amputee Aid here in Pittsburgh a lot, and they have a podcast. We're on there because that's another thing we see with recovery is, and you get into an accident, you have to get your leg amputated or whatever. Then you learn to sit, you learn to stand, you learn to walk, you learn to go to the bathroom. Nobody's teaching you how to thrust or have sex or masturbate. So it's not that we're going to teach you that, but we have to bring it into the conversation, because again, otherwise they're just grateful. Just be grateful you can do that. I have a friend who's 23. She had a sarcoma at 17. She has a catheter bag. Like, she's supposed to just be grateful that she's alive. 23 dating with a catheter bag, not sexy. And also, why aren't catheters better? It's the same plastic bag for 5 years. This affects a ton of people, but there's no advertisement for that on any of the websites that help sexual functioning. So that's always my thought, is that's where that needs to go, is to the medical providers, because nobody's helping. Nobody's saying, do you have sexual desire but have a catheter? We can help you, because they don't want to help them. There's no money there. So looking at, how to just advise those things too, seeing a pelvic floor PT, understanding what parts of your body you can use, how to use pleasure. Okay, psychoeducation. I attached a bunch of things Lauren either sent you or will go over, is just and Elise has tons of these things too. It's like the Sensate Focused handouts, which is a touch exercise. There's a show that was on Showtime called Masters of Sex, and they have it was based on sex therapy, came from Bill Masters and Virginia Johnson at Washington University, and they showed, in the show they do a good job of it, because Bill Masters has erectile dysfunction and Virginia Johnson touches him just on his forehead and then on his chest, and he gets an erection. And Sensate Focused is based on Virginia Johnson, who's she's a researcher, was a researcher, and her mom, when she was nervous, when she was young, her mom would trace her face with her hands. So she started doing that to Bill, and then he got an erection. So they started this whole Sensate Focused exercise off of the nerve endings. Again, it has nothing to do, it's not like your face causes erections. It's about relaxation to one area causes, blood movement to another area. So I like to use that, like using media. I'm doing a PESI talk in a couple months, and that's we're getting permission to use those clips, because you can't just like use those things all the time. Looking at workbooks, we do have a lot of workbooks, but there's also a lot of very dangerous things out there for people that is very guilt driven, very weight shaming, very sex negative. So that's where I always look at whether it's ASECT that I'm aligned with, and there's a lot of positive places you go to, like your medical community, and look at who are the authors of these books. So that's what I look at a lot, is like, who are the people that are educated in this? Do they have a medical background? Do they have a counseling background? Where are they licensed? Instead of, sex coaching, that it just means it could be anybody. Looking at, samples. So we have, it's funny, I have this right here. This is called Love Honey, and this is a place in Pittsburgh, a woman it's called Una that sells it. But this is a natural product that has cocoa in it. So, and it's a vulva moisturizer. So I don't sell those products, but we have like samples for things like that for people to try just because they get overwhelmed when you go to CVS and you're like, you don't know what to buy. So just having them, understand what these other like moisturizers, because that's something that's newer in the idea of like women have to moisturize their vulvas. So it's like, yes, this is, these are part of it. Then looking at the other ancillary providers that they can see. So dietitians, urologists, OBGYNs, I see the best results with collaborative care. Okay. And then when people were going through this is, these are just a little bit of like some tips is, I see this with people with rape victims a lot of times is they're so used to, and cancer survivors, somebody like me enters your space, I'm going to say, okay, I was 31, PR, ER, positive, HER2 negative. I had 9 surgeries, reconstructed, like, blah, 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 blah. You can stop them and say, I'm, I'm your pelvic floor PT. I need to know this. I'm your medical provider. I need to know this. So when I teach people that in the doctor space, I always say, like, make sure you enter in and say, hi, I went to medical school. I can prescribe medicine. This is what I need to know. Or stop them in between, because otherwise it just becomes that same diatribe that they do with all providers. I've had people have a PowerPoint. It's that like, what does this person need to know of my overall? Um, go through the basic stuff of like, are you feeling pleasure? Are you feeling pain? One of the other things is as a cancer survivor, people will, neuropathy is a lack of pain, but then there's numbness is on the pain scale, addressing that. If they have pain, one of my friends got cadaver nerves so that she would have feelings in her chest, and nobody told her she would only feel discomfort. So like this idea of like, what does this mean? What is the feeling? Do you have this at this point? Just kind of poking a little bit, and then have them say it themselves, because a lot of times the people that we're seeing in sex therapy are like, I don't want to say they have main character syndrome, but a little bit of they're used to a lot of hand holding, and we have to give them encouragement of self advocacy, and that's a big part of it. Okay, this is the going deeper into sexual history. I just want to make sure if there's any purity cultures or anything. I have a client who's Jehovah's Witness. In Jehovah's Witness religion, masturbation is the same sin as murder. So I'm not going to encourage him to masturbate. It's against his religious beliefs. So making sure that you can state work within their realm. Um, Understanding if they have their own hidden influences, like, I addressing, this is an uncomfortable one, but like trans people that were raised as, like, I have a colleague who, as my co-chair, is a trans female and transitioned at 50. So was raised as a male or socialized as a male. So when we, sometimes I will say, can I have your permission just to say, like, I'm saying a fact, but this also is like, it's not to be mean. It's to say, oh, you probably had this part of you that it's not a privilege, but it's also this thing. Oh yeah. It's giving that permission to be uncomfortable, and being inclusive. So one of the big ones that I see a lot are women hitting women and women hitting men. So we talk, I talk just about like you have for kids, hands are not for hitting. I don't need to educate you on, well, lesbians shouldn't hit and men shouldn't hit. No, no one should hit. It's just very basic stuff. We don't have to overcomplicate it. Okay, and then I have this like the sensate focused exercise that I use. How I feel about our sexual relationship is another like provocative way to just have clients ask things. The love languages is stuff that you guys have seen a lot. And then the languages of apology is it. I think Lauren will send it to you, but it's a very good example of, if you watch Seinfeld, I am a very big believer of put your sorries in a sack. I don't like sorries. I think it's silly, but I do need, hey, I did this wrong. This is what I'm going to do right. So understanding those things, then the yes, no, maybe list is like a yes, no, maybe of sexual activities. And the yes, no, maybe so list is a list of activities that you would do with another person for like polyamorous people. Um, the dimensions of touch is a similar thing of what are the touch that is satisfactory. Oh, sorry, I just saw that. the different touches. And then the childhood sexual development, I feel it is I'll share these ones with you. But the childhood sexual development is something that should be studied a lot more because it goes over which years and year by year of like different interventions or different growth spurts sexually. So I have a client who we were looking at, why was he having some like out of control sexual behavior? And, he didn't know why he's addicted to porn and going through this. And olden days, I would say, like, what was your first sex act? Like, what did you do? And really, I just asked him, what were you exposed to? And the University of Pittsburgh here is similar to WVU. There's a lot of housing, and then there's a lot of like, slumlord. Maybe there's some slumlords or whatever. I don't know what you have there. But anyways, his dad owned a bunch of houses that college kids rented out. So when he was like 7, 8, 9, he'd go with his dad. Well, guess what college boys play in their houses? Porn. They had porn on. And when this 8-year-old saw that, and me and him talked about it. I said, what do you think? I said, what was your first exposure? And we talk about it, and he's like, oh my God. And we think about it, and he's like, yeah, those guys, it wasn't anything to do with sex. It was that they thought he was cool because he looked at it and they're like, yeah, you like that, right? And then that was it. So, and you look at development, the sexual development, it's not about sex. It's about, oh, at 8 or 9, I'm looking for approval of men. So then that male approval then clicks in your brain, right? So I like to use those for assessments with people a lot. I use it as myself and I say, hey, my mom had breast cancer when I was 5. So you can look at what a 5-year-old's development, go to any kindergarten class, disrupt that, and you can kind of see, oh, this is, like where these areas are. Okay, so I've done a lot of talking, and I know I can go over some of the handouts, but I wanted to see if there's any questions because we have 7 minutes left. Oh, anything? No. All right, so I can show the handouts that I was talking about, just so I can
And while you're
yeah.
pulling those up, I'll comment. Lauren has those. So when
Okay,
she
great.
comes back next week, she will be sending all of those out to everyone.
Okay, fantastic. Yeah, so these again, like this is not stuff to be pull up. I can't talk. I can't do two things at once. So this was in 2000. This was when this was written, and I can't find anything that would be up to date. So I'm just going to kind of scroll through and show you. So it goes age by age. So like you go to like even age 1. But if you go down to say, we'll say like age 8 or age 9. Okay. Uh, Immediate or intermediate age, no longer a child, not yet a youth, characterized by self-motivation. 9 can put his or her mind to things of their own initiative. 9s are less dependent on environment support, like to plan in advance and have to think about things first before doing them. They can sustain repetitive tasks and are interested in perfecting skills. They're capable of objective self-appraisal and critical of others as well. So like it goes into all of these, like, want to be babied by their parents. They have a loyalty. Like it goes, this is such a great research that I've overused it and I want to find more of it. But it again just goes into these like different areas. The 5 languages of apology, just you can look at this with your spouses. It's very easy. Like, do you like, I'm sorry, I was wrong. What can I do to make it right? I'll try not to do that again, or will you please forgive me? So sometimes I know when I wrong somebody, I do all of these because just to cover your ass. So, sometimes it's how do we do this as a provider when you misgender? I do it all the time. I say the wrong names. I do the wrong thing. So you say, "Oh my God, Ellis, I'm sorry, Elise, I'm so sorry. I was wrong. I said your name wrong. Does it bother you? Is there anything I can do to make it right? I'm Elise, 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 Elise. I'm going to do it again. Please forgive me." I have a client who is from Syria. I have said she's from Armenia 4 times to her. And the reason I've said it to her, which is, and she knows this, and now I have to say, I always say Syria, 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 is because she's gorgeous. And the Kardashians are gorgeous and they're from Armenia. So it's that easy of a click of a dumb thing, but it's how do we just apologize for these things in those moments that can really disrupt our care. And a lot of times if they're seeing us, they need to see us. So that's where I'll look at that too. Um, the yes, no, maybe. These are great for um oh, wait, this is the yes, no, maybe. So the yes, no, maybe list, if you have like all my medical residents love this because this has, all of these different all the terminology. So if you can see like there's, this is not an inclusive list and this is not always up to date. But going in here, because I will ask people, well, are you kinky? And they'll be like, no. And I'm like, okay, do you use dirty talk? Yeah. Okay. Well, maybe you're a little kinky. Do you dry hump? Sure. Okay. All right. But then it's like, are you into fisting? No, God. Okay. So it's like, and then what are these things? There's also a term down here. So all my, everybody likes to look at like, what are these exact things? But when you're doing forensic interviews, it's very important. I don't know about West Virginia, but in Pennsylvania, rape is considered penis and vagina. So, looking at what these things are in that way, but also in different ways.
Dana, I
Okay.
just wanted to
Yeah,
thank you for coming.
you're
Um,
welcome.
because I think, for some people have heard me speak before, and I think it's good to get to see, although Dana is my mentor, how different sex therapy can present based on the sex therapist.
Oh,
And
yeah.
how that looks and what we talk about and what we address and how we go over things and what our personalities look like and how what one person might view as a certain way or and can engage in sex therapy a different way with me might view that experience very differently with Dana. And it's not good or bad, but it's just what can that person get out of it because therapy is so different and it's such an experiential space for everyone. So
Well, and should they see you? I always say sometimes you need an Elise, sometimes you need a Dana, sometimes you need an Elise to find a Dana. It's okay.
yes.
And in the same with medical providers. I remember going through breast cancer. It's like, well, who do you want? And I remember being like, I don't know. Like, you could tell me I want the best, but I don't, that's so subjective. I want a woman who's competent to do my plastic surgery. But I was okay with dudes. Otherwise, I was sick of that. It's like, how do we just say okay? And understanding that. But no, I appreciate that. Thank you. And I know I'm doing another one of these, I think on something else. But yeah. So you have my info if anybody needs anything or consultation. I do group supervisions that are free for anybody who's not local, and you can just consult anytime. I spilled a drink while I was talking, so that's why I'm cleaning up now. It's about recovery and making it look seamless. So
Well, thank you so much, Dana.
thank
We
you so
really
much.
appreciate your talk today. And just a reminder for everyone, if you would like to get the CME credits and have never received that from us before, I did put the link again to the CME registration, and it's in the chat. So we do thank you. And as I said, when Lauren gets back next week, she'll send out a follow-up to everyone that has a PDF of the slides and all of the handouts of things that Dana had referenced today.
All right.
So thank you
Thanks,
all so
guys.
much. Enjoy the rest of your day.
All right. You too. Bye.